So now I wanted to spend a little bit of time talking about the therapeutics, how we start with a baseline regimen for these patients, whether they come in complaining of ocular surface disease or they're a pre-op patient and we're trying to prepare them for surgery. I was hoping maybe Peerya could start with that.
Yeah.
What's your baseline regimen?
For taking care of
starting with a new patient, what's your maintenance?
So, once you've taken your diagnostic tests and narrowed down where your patient falls in, do they have MGD? Do they have eyelid abnormalities, poor blink reflex? I try to first figure out, is there a lot of inflammation? If there's inflammation, you're required to treat that. And a lot of inflammation comes from, bacterial overgrowth on the eyelid, the presence of bacteria. And so I think lid cleaning and lid hygiene is really important. We've incorporated the Avenova cleanser into our practice. It's something that we actually write prescriptions for it. It's just used twice a day. Patients, especially those with rosacea that tend to have that bacterial overgrowth as kind of one of their root problems. We know that rosacea skin types like bacteria like all that extra oil that's there. And so I find that it's particularly helpful in those patients to really help kind of calm down that propensity towards, one, forming these biofilms along the eyelid, but two, to maybe, calm some of that underlying inflammation.
Yeah, we've been using a lot of Avenova too, and I know, Liz, you had mentioned that you were using it in your practice, and you as well. Yeah, it's really made a big difference for our patients.
I've had my rosacea patients use it on their skin, on their face, and it's been really effective.
It's really been a nice tool.
I think, especially as you said, if you're looking at the lid margin and there's any anterior blepharitis, any crusting of the lashes, and if there's any saponification, if there's meibomian gland disease, it's really important to have that cleansing and improve the biofilm, most definitely.
Well, and also in our surgical patients.
Yes.
I mean, this is one area where infection is something that we all take very seriously, and anything that we can be doing to help lower those bacterial counts so that you're not putting your patients at as high risk, I think is really a no-brainer.
100% in my patients where I'm particularly concerned about the anterior blepharitis, because we know that right at the root of the base of the lashes you're going to have a lot of that bacterial overgrowth. I mean, if you are going to start, and our number one regimen is going to be doing hypochlorous acid topically for those patients, you don't want to do it and then send them right into surgery, because you're maybe potentially exacerbating a problem because you're releasing everything, right? So for those patients, I am scheduling their surgery for 4 to 6 weeks out, but I'm instituting the topical hypochlorous acid from the very get-go in order to make sure that we really cleanse and sterilize the lid margin in preparation for surgery. And that is a very nice way of kind of preparing that patient.
And that's the key to screening all these patients. So we're screening all these patients when they come in for their consultation, which would be 4 to 6 weeks generally before surgery. And then we can start them on the Avenova, the lubricant drops if they need, a steroid or, Restasis or Xiidra or something like that to help pre-treat before we make our measurements. Of course, we know Alice Apatropoulos had a wonderful publication this past year that showed us how our measurements for our IOL calculations really depend on that ocular surface, so pre-treating is so essential.